All right, so hemostasis. Basically, you cut yourself, three things happen. First thing, you're driving, the first thing that happens with a motor vehicle accident, everybody like shuts down. Whoa, what's happening here? We get all shooken up. That's what happens first. You cut yourself, you get this vasospasm. It just goes into vasoconstriction for a short time. Doesn't do much. You know, all the cars stop suddenly. It doesn't do much. It's not going to have another accident, but it's really not doing much. It's a very quick, brief thing. Okay? Then the platelet plug forms. All the platelets rush there, just as much as the paramedics are going to get to the motor vehicle accident. They're going to stabilize things, but it's not going to be 100%. It's just going to stabilize things until they can get into the hospital, where you're going to do what we have, the full-fledged coagulation. This is only going to give you this little plug, all right? And then it's just, you got to put glue in there. If there's no glue in there, you touch it, it's going to bleed again. You know what I'm talking about, right? So you have that little time over here. The coagulation is the important stuff. So in a picture form, all right, here's a blood vessel. You broke it. First thing that happens is vasoconstriction. We have this vasospasm. It's not a big thing that it does, but it does happen. Then you're going to have all these platelets start forming this plug here to try and stop blood flow going out of your body. It's a temporary fix. But if you just touch this, the platelets will move and you'll bleed more. Right? So it's just a temporary fix until you get coagulation. We get this yellow stuff in here that starts building this glue in this wall over here. And then, a day later, it's not going to bleed again. So that's in 3 stages: vasospasm, platelet plug, and coagulation. So let's look at the platelet plug a little bit further. This is a platelet. Here's your blood vessel. If there's a hole in the blood vessel, well, the platelet isn't going right to where the blood vessel is. It has to first look for this, what we call von Willebrand factors. Von Willebrand factors float all throughout, they're little proteins that just float all throughout the whole body in the bloodstream. And they look for these little areas here, and they kind of attach there. The platelets need to bind to von Willebrand's factors. If there is no von Willebrands over there, the platelets just keep on going. And once this binds over here, then this platelet sends chemicals to get more platelets over there so that this whole thing can now stop the bleeding. It's a flow. That's how a platelet plug works normally. But now, in pathophysiology, put it together. You can have a disease where you're not going to have von Willebrand's factors. You're born like that. If you don't have it, platelets are not going to happen. Or you might be very low on it, so you might not see it until you got more hemorrhaging. This is called von Willebrand's disease, and it's more common than what you think. You just don't have the von Willebrands. What do? Well, we can actually make the von Willebrands in a bag, and we can actually give you it. I think it's like every 6 months or so they'll be giving that to you. A lot of times we don't notice this until the girl has her first menstrual period, and she's bleeding heavy. So those are that's one thing that we want to rule out. Is it because of a hormonal thing? Is it because of von Willebrand's? That kind of thing. Okay? If you have low platelets, you're not going to get this. So if you understand the normal, then you can understand what, if you remove certain things, you've got the disease process going on. Okay? So coagulation. So now you saw the platelet plug. Coagulation. Coagulation is a series of chain events. This is all review kind of stuff, so I'm going to speed it up. But you have all these clotting factors, and all the clotting factors are made from the liver. And they have 2 different pathways to make this coagulate, this fibrin. We have the extrinsic pathway and the intrinsic pathway. The intrinsic pathway begins with stuff that came from the blood itself, within the blood flow. Intrinsic, within the blood. Extrinsic pathway comes from stuff outside of the blood. from the endothelial layers or the tissues of the blood vessels themselves. The blood vessels release or secrete certain things. So we need both of these to make sure you have good clotting going on when you cut yourself. They both, the intrinsic and extrinsic pathway, lead to what we call the common pathway, where it makes the prothrombinase, and a prothrombinase will make prothrombin become thrombin, thrombin will make fibrinogen become fibrin. Fibrin is that magic glue that I've been showing you about. So the picture you saw before with all the yellow, that's fibrin, that's the glue. So here you've got the extrinsic pathway, the intrinsic pathway, leading to the common pathway. These are all clotting factors. They're all made from the liver. It goes to factor 10. Both of them will go to factor 10. That's where the common pathway begins. Once this happens, it's going to make prothrombin activator turns prothrombin to become thrombin. Thrombin then makes the fibrinogen into fibrin. And fibrin is that magic glue that you have to do this whole thing for. If these factors are gone, one of these factors are gone, that's hemophilia. They're not going to be able to clot the blood properly. We can also assess the integrity of each one of these pathways. We can actually test the extrinsic pathway by a certain blood test. We call that blood test the prothrombin time, the PT. That tests for the extrinsic pathway. We could also do another one called the PTT, which is the partial thromboplastin time. And that goes this way. So a lot of times you will do blood tests as a nurse, check the PT, PTT. That's what they're talking about. There's a timing for that. I kind of remember the extrinsic pathway only has a few factors here. But the intrinsic has many factors here. So the PTT has more T's in it, more factors. So that's intrinsic. I don't know if that helps. This has fewer clotting factors, so they're only going to have one T in that one. Does that make sense? To help you with which one. Sometimes you just want to test the PT. Save money for the patient for certain things. For instance, maybe later on, the PT will test for warfarin or Coumadin, and the PTT will test for heparin. So if you're just giving heparin and you want to see if the level is good or not, just test for the PTT. You're wasting money doing a PT. Does that make sense? But you need to understand where that's coming from. Okay. Some questions on that? All right. So vitamin K. Vitamin K is stored in the liver. And the liver is going to use vitamin K to make specifically clotting factors 2, 7, 9, and 10. Now, the liver makes all the clotting factors, but it needs vitamin K to make specifically 2, 7, 9, and 10. The way you get that is vitamin K in your diet, cereals, that kind of stuff. I don't know what special K is that. That's not really, I don't know. Or it's made definitely by the bacteria. Remember we talked about symbiosis. Normal flora that's in your large intestines, they will, or small intestine rather, and they will actually make some of the vitamin K for you. All right. Also, calcium. Calcium is factor 4. So yes, you need calcium to clot blood. Remember how I said, I usually tell people this in A&P1, that, calcium, what does calcium do? Mostly everybody at that point early on, they all say, oh, it makes your bones and teeth strong. Okay, we learned about that. But if calcium has 10 important things to do. Making bones and teeth strong is way down on the bottom of the list. You've learned that now calcium is more important for nerve conduction and muscle contraction and for clotting. I mean, if you don't have muscle contraction, if you don't have your heart pumping, who cares if your teeth are strong, right? So that's why we always have to have a constant supply of calcium that's in our blood to do all these kinds of things. And that's where the PTH and the calcitonin come in to make sure we have enough over there, not overdoing it either. So let me ask you this. Now that you learned about this, this is where applying or application happens on my exams. Why is it that if you have liver disease, cirrhosis, hepatitis, that if you fall down, you're more prone of bleeding more? Right. Well, it does all the clotting factors. It just needs vitamin K to make these four, but it does all the other ones. That's exactly what I'm looking for. So here's what I'm saying. Here you have clotting factors are made from the liver. Clotting factors will cause coagulation. So my question is, if you have liver disease, why would you have problems clotting? And she hit it right on the nail. It's because the liver can't make clotting factors. So that's where that comes in there. So, you know, make a list of all the different things calcium does. Make a list in your head so you always have to rely on it. You want to write it down to see if you can remember it. Super. Always learn. There's never a time you're going to the medical field, you're always learning. You can't stop. It just keeps on coming up. All right. So, so that's vitamin K and calcium. We need that in our diet, or at least by the back. Okay, so hematologic diseases, okay, or disorders. So the way I'm breaking this up, if you look at the whole thing here, we're going to first talk about red blood cell disorders, namely anemias, when we have a decreased amount of it, of red blood cells, and we have too much red blood cells. It's a condition called polycythemia, okay? Not so much about that one, but a lot about anemia, so we're going to talk about that. Then we'll get into white blood cell or leukocyte disorders, and we'll be talking about leukopenia. I'm going to have a suffix of the word, or the suffix penia means a decreased amount. So we're going to see a leukopenia or thrombocytopenia. When you see penia, think of a low amount, as opposed to leukocytosis. If you have a suffix of cytosis, that means an increase in amount. Okay, so we're going to talk when we have too little white blood cells or too many white blood cells. What does that mean? But of course, we're going to spend a lot more time, not a whole lot, but I mean, we're going to spend some time on leukemias when we have cancer of the white blood cells. Then we're going to get into platelets and hemostatic disorders. Now, the way that the book has it is that these disorders are mainly in a different chapter, chapter 6. The one that all of you loved about was fluid electrolytes, acid-base balance. Well, they chose to put a lot of the hemostatic disorders in there. So I didn't have you guys know that part when we did fluids and electrolytes. It was about 10 pages, so page 158 to 168. So I think it's better to throw it in with disorders of blood. So that's why I'm throwing it into this one. It's much better to put it here. So you're going to have to go back to those pages in the chapter, although most of the stuff that I'm going to ask you guys to know is coming from my PowerPoints or in this lecture itself. So, but if you need to expand or if you're still confused about something, you're going to find that information in a different chapter, chapter 6, okay? And then the last part, which we're really not going to be doing much on, is lymph node neoplasia. We handled all that when we got into the immune system. But if you look in our book, our textbook, they throw that part, lymph node neoplasia, into here. So if you want to go back and look at that stuff, you can more than welcome to do that. You still need to know for the final exam, but I'm not going to put this material into the exam that's about this the blood disorders. Okay, it's mainly going to be on red blood cells, white blood cells, platelet, and the hemostatic disorders, which again is going to be in chapter 6. Okay. All right, so let's talk about lab tests, okay? Blood lab tests, and that's going to be your a little bit of your bread and butter too when you do all these vena punctures. And what does it mean when someone says you have to do a complete blood count or a CBC? A CBC, or a complete blood count, is really going to check for all the formed elements, the things like the red blood cells, the white blood cells, and the platelets. So they're going to check for the amount that's in there. They're also going to break down the red blood cells, or some specific or sub-specific tests concerning red blood cells, namely the hemoglobin and hematocrit. That's going to tell us, help us to see if the person is anemic or not. We'll just touch on this. The MCV, which is the mean cell volume, kind of tells you the red blood cell size. When we deal with diseases like iron deficiency versus vitamin B or B12 deficiency, one is going to make the cell look bigger, one is going to make it look smaller, and that's where that's going to come in. We also have the hemoglobin concentration, which is referred to as the MCHC, and that's what we're going to deal with that a little bit, not too much. We're also going to have to break down the white blood cell. Sometimes it's a special test. When we ask for a CBC, we're just going to get the number of white blood cells, that's it. But if they say we want a CBC with a diff or a differential, what they're going to ask for basically is, of the white blood cells, we need to know how many basophils you have, how many eosinophils you have. Because as you've seen with the previous chapters, having an increase in eosinophils is going to tell us that parasitic worms may be the case, or there's some allergies. So sometimes if we have a high white blood count, we're going to also need to know exactly which white blood cells are increased, because that's going to help us with our diagnosis. It's going to help us with, so they're going to give us percentages of all 5 white blood cells. We can also detect if any of the white blood cells look weird. If so, it may be that there's leukemia involved. And we're also going to see possibility, as we talked about in one of our earlier chapters, immature white blood cells, we'll see them as bands. Remember I said it was your bands and your shift to the left? That's what that's going to be. And that kind of tells us that there's an acute inflammatory process going on. So those bands would help us to understand that there's going to be, for some reason, they're making more white blood cells, and you're going to see a lot more of these immature white blood cells appearing that are eventually going to be adult, okay, more mature. So if we see bands, we know that we're building our army. There's something going on inside the body, okay? We also have something that's analogous to the white blood, the bands for the white blood cells. We have something called reticulocytes. Reticulocytes are immature red blood cells. So if we're anemic, if we're losing a lot of red blood cells, then our body's got to make more red blood cells from our bone marrow. If that happens, some of the earlier stages of a mature red blood cell is going to be a reticulocyte. And we have a certain percentage where that's going to increase if we have to make more red blood cells. So if we see a reticulocyte that is very high, that means we are losing a lot of red blood cells and our body's making a lot more. Same thing with our white blood cells, that there must be some inflammatory process going on, and we need to get more white blood cells than usual, so we're going to have a lot more of these bands coming out. Okay. Also, we could also check for the shape of the red blood cells, and if there's any parasites, like we talked about Plasmodium with malaria. So we can do a blood smear to actually check the shape of the red blood cells, because we're going to talk about some of them could be sickle, like sickle cell disease. They can be very round and big. It could be spherocytosis, and we'll talk about those. So a blood smear can help that. Okay. Now these are the normal blood values that you should know. Okay. There isn't much for us to know in terms of lab values. These are ones you should know. You're going to see them quite often. So hemoglobin in a male, it's 13.5 to 18 grams per deciliter. And females are a little bit less than that. And that's really owing towards men have more muscle mass, and that's why we're seeing a lot more on there. The hematocrit is going to be the percentage of red blood cells in the whole blood. Okay? Let me show you something up here. Okay. So what we have here is when you give blood, you're going to give whole blood. So you're going to have this test tube of blood. Okay? And we refer to all this, and it looks all red, and this is going to be referred to as whole blood. Okay? Then what we do is we take this and we put it in a centrifuge. And in the centrifuge, they spin, 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 spin for about 5 minutes, and all the heavy stuff goes down to the bottom, and all the light stuff goes to the top. When that happens, we get a nice delineation happening over here. And all the heavy stuff turns out to be the red blood cells. And they're going to be all down here. This is going to be your red blood cells. And it makes up approximately, depending on female or male, but approximately 45% of your whole blood, right? In this area here, very small area, little bands of beige area. We call it a buffy coat or a buffy layer. In there is what we're going to have as our platelets and our white blood cells. And that's going to make up actually less than 1% of our whole blood. Then the lighter stuff, which is mostly water up here, but you're going to have other things involved with that too. This is going to be our plasma. So it's mostly water, about 91% of it is water, okay? But that's where you're going to find all your hormones, that's where you're going to find oxygen gases, fibrinogen, proteins, ions like sodium, calcium, magnesium, that's all going to be there. And that's going to make up the other 55% or so, okay? So what we got here is whole blood, and the percentage of red blood cells in our whole blood, we give that a special name. That's called a hematocrit. The hematocrit is the percentage of red blood cells in the whole blood. And like I said, it's about 45%, depends on male or female, okay? Rough estimate is if you know the hemoglobin, you know the hematocrit and vice versa. Because the hematocrit is usually 3 times the amount of the hemoglobin. In other words, if the hemoglobin in a male is 10, then we could guess that the hematocrit will be at 30%. If we know that the hemoglobin in a female is 15, then we know that the hematocrit is around 45%. Vice versa, if we know that the hematocrit is 20, let's do my math easier, is 21, okay, 21%, then we know that the hemoglobin must be around 7%. I mean, not 7%, but 7 grams per deciliter, okay? So that's what the rule of thumb is on there. The other things you should know is reticulocyte count, all right? Normal be 0.5 to 1.5%. White blood cells is going to be anywhere from 4,500 to 10,000, okay? If you have a platelet count, normal is going to be 150,000 to 400,000. So anything more or less than this, you're going to have some kind of disease process going on, okay, on all these things. All right?